Good evening. Welcome to SpectraCell's Thursday night webinar program. We are excited to bring you Alzheimer's and Type 3 diabetes presented by Dr. Ron Grabowski. Slides and other educational materials are available for download in the resources box on the left of your screen. You may submit questions in the Q&A box, and if time permits, we will answer these at the end of the presentation. At this time, I would like to welcome back Dr. Grabowski.
Thank you, Jessica. Good evening, everyone. I'm excited tonight to talk about this condition. As you all know, all of us have either had a patient that has had this condition, or we know some friends or relatives that have an individual with Alzheimer's. And what's exciting about this particular topic is that you will see a significant impact that nutrition has on this particular disease. And also, you will see some other correlated conditions that really tie into this. So it's not just one condition like Alzheimer's that we have to look at, that we actually have to look at some other comorbidities that are associated with this. As you know, this condition is increasing on an annual basis. In the next several years, we find out that it's going to increase significantly. And once again, we're going to find out that nutrition is going to have a bigger impact on every discovery that we come across. It's actually a combination of nutrients that we have found that have a big impact on this. So it's not one particular nutrient that you'll find that really solves or prevents this condition, which is exciting because it, once again, correlates to customizing your therapy with these particular individuals. The thing that's really important about this particular condition is not just the signs and symptoms associated with, but what the impact is on family members as well. And one thing that we have found is that people that are caregivers to these particular individuals are significantly impacted. And in fact, some research shows and statistics show that about 1/3 of individuals that take care of an individual with Alzheimer's actually go on antidepressants. And as you can see here, it's a sixth leading cause of death in the United States, and almost 80,000 deaths per year are a result of this condition. Now, as you all know, the histological relationship of this, that we talked about the aggregated amyloid B peptides that really come into play, and also the neurofibrillar tangles that are associated with this, and also known as associated with the protein tau. And so as a result, what's important about this is how do we prevent this from happening? Are there certain processes that we look at or certain pathologies that we have to correlate with this to make sure that these processes don't occur? So one of the things that happens when there's damage, of course, we have a significant loss of the synapses. The neurons are once again affected. And you can see it's in the hippocampal and the cortical areas that are really affected. And this has been published since the early 1990s. And once again, we're finding out today that things that have happened before with various vitamin or mineral deficiencies have really started this whole ball rolling in regards to the brain integrity. Whenever we look at a major disease, whether it's cardiovascular disease, diabetes, osteoporosis, of course, one of the things that always comes into play is there a genetic relationship? And you can see that there have been 3 genes that have been identified as a familial relationship to Alzheimer's disease. However, as you can see here, these genes affect less than 5% of the cases. So taking that into consideration, what is that other 95% that's really involved in the etiology of this particular disease? And that's what we're going to talk about tonight. And even though I only have like an hour to talk about, and I'm not going to be able to talk about all the nutrients associated with this condition, we're going to hit some major nutrient relationships that have been highly published in the past decade. In addition to the nutritional deficiencies, of course, we have to look at lifestyles. And you can see diabetes comes into play, of course, hypertension, obesity, whether the person smokes, definitely has a big role. Depression. We find, and you read literature all the time, that people that have a history of depression, that they have a higher incidence of Alzheimer's. or people that have diabetes, they have a higher incidence of Alzheimer's. Even migraine headaches, they've shown some relationship of migraine headache individuals may have a higher tendency for Alzheimer's down the road. And I'm going to try to tie those particular conditions to this particular disease. And you will see there's some commonalities in regards to vitamin or mineral relationships. How does one particular nutritional deficiency affect Alzheimer's or cause Alzheimer's, and also affect possibly diabetes or high blood pressure or depression and so on. And that's what's so interesting about this. So instead of saying to your patients, oh, you have depression, you may have a higher incidence of Alzheimer's, is look at depression, see what nutrients are related with depression, and see if those same relationships are also connected to Alzheimer's. One of the other things that we talk about in addition to Alzheimer's, or people talk about, is, of course, MCI, or mild cognitive impairment. And, of course, you can see here that these people don't necessarily have dementia, but, once again, do have memory complaints with, once again, total loss or limited loss of daily functions. And as you know, with Alzheimer's, this becomes a major problem, that these individuals aren't really able to function with the normal activities of daily living. There is some relationship, though, with these particular individuals. As you can see here, about 10 to 15% of these particular individuals may actually go into Alzheimer's, and, of course, 1 to 2% of these individuals, of course, have been shown to have normal cognition. But once again, when you're talking about MCI, you're talking about Alzheimer's, is there somewhat of a connection from a biochemical standpoint or nutritional standpoint that can really tie these two together, or once again are related like these other conditions we talked about? So what are some of the risk factors and connections of these particular individuals and their Alzheimer's down the road? One of the biggest topics probably today is the relationship of weight status, and of course eventually when you talk about weight, you're going to talk about insulin resistance, or you're going to talk about diabetes. And the thing is that we know that weight is still a major problem today in the United States and other countries, and we're always looking for that special diet or that special remedy that's going to help with weight loss, whether it's exercise, whether it's a diet like the ketogenic diet or the Mediterranean diet or the gluten-free diet or whatever. But one thing we know that connects a lot of these together is inflammation. And so you're going to hear me talk about inflammation today and what nutrients are connected to that in regards to this particular pathology, and also how can we affect those particular nutrients and also affect obesity and possibly Alzheimer's down the road. So as I mentioned, that one of the concerns or one of the relationships with weight gain or obesity or overweight status is insulin resistance. And so when people talk about insulin resistance, of course, we're always looking at, are they consuming too many carbs, not enough protein, are they consuming enough fat in their diet as far as proper fat, are they exercising, so on. But one of the things I think that's really being lost today with this condition and several other conditions is looking at the micronutrients. I just saw an individual this past week that he was recently diagnosed with diabetes. He's a marathoner. He's got 6.2% body fat. His dietary history was excellent. And all of a sudden, he started to develop insulin resistance. And he said, I don't understand this, doc, that here I am, I exercise, I eat healthy, and I get diabetes. And most of the time, diabetes, I thought it was associated with weight gain. Well, it is, but I will also connect that as how do these thin individuals have insulin resistance and possibly lead themselves down to the road of Alzheimer's, in addition to these individuals that are overweight or obese and also have the same situation. And you're going to see that there's some very interesting ties when we come to the micronutrients in this aspect. So as you know, that the American Diabetes Association has defined what really diabetes is. And you can see here, all of you are probably very familiar with these guidelines in regards to what diagnoses an individual with diabetes. And this is what we look at. But are there preliminary factors, whether it's protein, carbohydrates, fats, or micronutrients that are really leading us down this road. And that's the thing that I really want to emphasize today, is that there are things that are happening to these individuals that look healthy, that are normal weight, that maybe exercise, have other issues in their life, which I'll discuss as far as medication or lifestyles, that are causing some of these deficiencies to occur, that are causing us to have insulin resistance, even though they may not be, once again, overweight. So when we talk about insulin resistance, and you're all probably aware of this, but just to recap this in a sense, is you have to ask yourself, one, is the individual making enough insulin from their pancreas? Two, is the pancreas secreting proper amount of insulin? And three, are the insulin receptors working at their optimal function? And I'm going to show you how the research shows that certain micronutrients are involved in all of those possibilities. And so some medications try to do the same thing. As we know, the TZDs affect the insulin receptors. Okay. On the other hand, metformin doesn't affect the insulin receptors. It affects the way glycogen, of course, is converted into glucose, breaks down and goes into glucose in regards to elevating serum glucose levels. And then, of course, we have the sulfonylureas, that those particular medications are working more on the pancreas. But the point is that when we look at insulin resistance and we tie it into Alzheimer's, is how do we affect that particular process? And that's where we're getting the information in regards to the benefit of certain nutrients with this particular condition. Whether you use the term burnout or taxed in regards to pancreatic function has been taxed for several years, or whether it's overstimulated as far as damaged by too much carbohydrates, whatever terminology you've used with your clients or your patients and the literature has shown, the point is that can we get to the point where we are demanding more and more from our pancreas and we're not able to keep up with that demand? And can that be, once again, a cause of insulin resistance? And we have found that that can definitely be the case. As you're aware, 90% of all diabetics are non-insulin dependent. And so there are medications that, of course, aren't insulin related that treat the type 2 diabetic. And they attack different functions. As I mentioned, they attack the pancreas, they attack the liver. We have some that affect the uptake of carbohydrates from the GI tract, and of course, we also affect the insulin receptors. So when we are looking at these particular individuals, the thing that we have to keep in mind is they may have insulin resistance, but they may not at a certain time show a significant amount of insulin in their serum. So what I mean by that is when we look at these individuals, they're having problems with their glucose, but we're not getting the typical findings from these individuals, meaning an elevated serum insulin that's showing that their insulin receptors are being, of course, abnormally functioning. This is why it's very important that we look at things like C-peptide. Are we able to even see if that patient is making enough insulin? Because a lot of times, if you just pull a serum insulin on an individual and it's normal, you might think, well, they don't have insulin resistance because their serum insulin is normal. But if their C-peptide is abnormal, as far as abnormally low, once again, they're not able to make that insulin, so of course they're not going to have an elevated insulin. But at the same time, they could have insulin resistance. And so that the way you were trained, if you were trained that you're going to more or less diagnose someone with insulin resistance only if they have an elevated serum insulin, then once again, this is misleading. And that's why, once again, if you look at SpectraCell's cardiometabolic panel, that they include things like C-peptide, they include the adiponectin, they look at the leptin, they look at various factors that are precursors or are indicative of those particular functions of the body rather than just looking at serum insulin. We also have to always look at, ethnicity and gender. Are there common things that we have seen with these particular individuals? And you can see here that once again, we usually look at metabolic syndrome or insulin resistance or diabetes, more common in, once again, the African American versus a Caucasian individual. And what's interesting about this is you will see, I'll bring this back up when we get to certain nutrients, why that may be. One of the things, and I'm as guilty as anybody of this early in my career, is when we would see someone with a condition, say high blood pressure, cholesterol levels being elevated, or diabetes, we have the tendency to ask, did your mother have this, or did a sibling have this? It must be hereditary. Is it really hereditary, or is it these individuals have a similar lifestyle that has caused the same nutritional deficiency? And when I talk about nutritional deficiency, I'm talking about micronutrients, that's being accommodated with these individuals that's causing the same condition to occur. Because if it's hereditary, why doesn't it happen early in life? Why do these people all of a sudden maybe get diabetes at 39 years of age, or maybe 50 years of age? Or why do some people maybe display Alzheimer's-like presentations at 60 and other people don't present until like 80? Is there a reason why that's happening to these individuals, and is it rather than just, once again, a hereditary factor per se that everybody talks about? So you can see that there's been some studies done, and we've looked at various findings, and as I mentioned earlier, that C-peptide is definitely one of the things that we want to look at. And if you look at the bottom bullet here on this particular slide, you will see in the Nurse Health study found that higher C-peptide levels, once again, this product is used to determine if insulin secretion is occurring, also was beneficial to be related to cognitive decline in women. So it's a very important marker that we look at, but yet a lot of clinicians don't use. They usually, once again, use the serum insulin finding, or they look at the HbA1c, or once again, they may look at fasting glucose and repetitive fasting glucose, and that's how they determine insulin resistance, and yet they don't look at C-peptide, which is a major player. In the literature, if you go into the literature, they now talk about what they note is type 3 diabetes mellitus. And these authors of this research correlate this, of course, with Alzheimer's. And the reason why is because there's a strong relationship of insulin resistance with this disease. And once again, we're going to talk about inflammation. We're going to talk about various nutrients that are depleted and aren't able to allow these organs that I mentioned to function properly. But the point is that one of the major things that we can't let go of, and we always have to keep in mind, is on the bottom bullet there. It says oxidative stress. So what are we doing to the body that's increasing our oxidative stress that could lead us down the road to these particular conditions, whether it's diabetes, mellitus, or Alzheimer's, or some other chronic disease? And I want to go back real quickly to that patient I was talking about that came into my office this week that has a 6% or 6.2% body fat, marathoner, and once again eats healthy, but that's the cause of oxidative stress is heavy exercise. And we forget about that because we're always preaching to our patients, you have to exercise because exercise helps with insulin resistance or preventing diabetes, or preventing, of course, overweight or obesity, and preventing cardiovascular disease, and on and on and on. The point is, though, if the person's exercising, especially at that level, are they consuming enough nutrients, macronutrients and micronutrients, that are able to sustain that level of activity that isn't causing an excess or an increase of oxidative stress that will eventually cause damage to certain tissues? And the answer is that most people aren't doing that. most people are over-exercising without the proper nutrition, which is leading them to some of these major pathologies. And that's just not my thought process. That's what the literature shows, and I see it in my office on a weekly basis. So I think it's very important. But the point is, it's not the same for everybody. One nutrient may be low in a marathoner that causes oxidative stress to be increased, and 2 or 3 other nutrients may be low in another marathoner that comes in. So we can't shotgun these people and say, oh, just you all take vitamin D or you all take CoQ10 or whatever. We really have to make sure that we customize it for these particular individuals. So as I mentioned, that definitely diabetes mellitus and Alzheimer's disease is highly connected. We know right now that diabetes mellitus is at its all-time high in the United States. It continues to be a problem. Of course, the pharmaceutical companies are constantly trying to develop new medications to manage this particular condition. And once again, people have to understand that we need to address the nutritional standing of that individual before these particular conditions happen. And if we don't, it's going to lead us down the road to these conditions. So what are some of the, once again, the proposed mechanisms that are associated with diabetes mellitus and Alzheimer's? One, as I mentioned, insulin resistance. Are the insulin receptors working properly? 2, is the insulin being produced at adequate amounts? So the receptors may be working, but the pancreas may not be functioning properly. And that goes back to that one slide when we talked about burnout. Next, once again, is there a factor involved, things like insulin growth factor signaling? Is that being impaired? And, of course, glycation of end products where we get to the point of increased oxidative stress. And then eventually, of course, we talk about the vascular inflammation of these particular individuals. So there was a study conducted by Harrison Associates that showed that vitamin D deficiency definitely was associated with diabetes mellitus. And I'm going to talk about vitamin D quite a bit tonight because, as we all know, depending on the individuals that you talk to or you read about, anywhere from 65 to as high as 80 or 85% of the U.S. population may have a vitamin D deficiency, or if not deficiency, inadequacy or insufficient amount, whether you look at the serum level of 20 nanograms per deciliter or 30 nanograms, either one of those, the patient has a problem with vitamin D. But then we look at intracellular, where all this biochemistry occurs. And once again, we have to look at the Krebs cycle and glycolysis and beta oxidation and so on. So once again, we have to make sure that all those nutrients are present in order to keep those functioning. So when we look at vitamin D and its role in diabetes and or insulin resistance, once again, studies show, and this was published once again in numerous pieces of article, but I just picked out one particular reference here, that deficiency of vitamin D impairs the production of insulin, the secretion of insulin, and also the insulin receptors. So 3 mechanisms vitamin D has an impact on with diabetes / later down the road, Alzheimer's. And this is why it's so important. And I'm not going to talk about this a lot tonight because of time, but we also know that serotonin is getting into the literature in regards to relationship of Alzheimer's. And vitamin D is required to make serotonin, which a lot of people don't know or realize. And so that's very important. And then once again, I'm going to connect some other nutrients to vitamin D because vitamin D doesn't do these things by itself. It needs assistance or it's synergistic with other nutrients that are very, very important. So once again, when we look at the status of vitamin D, and this is just quoting some serum levels, you can see that 20 nanograms per milliliter is considered deficiency, and then if you're between 21 and 29, you're considered insufficient. And then, of course, there's other pieces of literature out there saying that, no, we should move to 50, and some say between 50 and 70 are adequate. And then there's other pieces of literature that say if you go over 100, that you may have some cardiac compromise with an individual if you're dealing with the serum levels. But once again, I've found a significant relationship with intracellular in these conditions as well. And that's what's very important because that's where our biochemical pathways occur. So what happens if we take too much vitamin D? So if everybody says, well, I don't want to get Alzheimer's, so I'm going to start taking a bunch of vitamin D. Well, if you're looking at serum levels, once again, you're looking at 150. But as I mentioned, there is some other literature that says that if you go over 100 nanograms per milliliter, that may be involved with some compromise. Of course, we always have to worry about calcium relationships, and of course, some people talk about certain dosages of vitamin D cause an increased chance of kidney stones. But I think we also have to realize it can't just be that one nutrient. There might be some relationships with other nutrients that may prevent the kidney stones. Or if you've been in practice for a while, you realize that when you were in practice, if you've been in practice for 20 years or more, that you were probably instructed like I was, that, don't ever give more than 800 IUs of vitamin D a day because you can cause kidney stones and hypercalcemia, which can cause other problems as far as from cardiac and skeletal muscle involvement and so on. And then you look at today what's happening with the literature that we're pushing 5,000, 10,000, 15,000, even 20,000 sometimes per day in people that have MS or other autoimmune diseases. So I think we, once again, have to all realize that when we start to use these dosages, that there can be some compromise, there can be some adverse effects depending on the individual, but that's why we're clinicians. We constantly monitor these individuals, and we know we have to monitor these individuals to prevent these things from, once again, happening. So, once again, when we're looking at this, we look worldwide, how many people out there may be in this category of deficiency/insufficiency. And you can see that they guesstimate about 1 billion people worldwide suffer with this. Now, is that really the adequate range? If people move it up and say, no, we really need to be at 50, or we need to be taking a certain amount to get to a certain level to prevent these conditions like diabetes and autoimmune diseases and Alzheimer's, then the number is going to increase significantly. And are these people taking medications out there that are predisposing us to some of these deficiencies that I'm going to talk about that are causing these things to occur as well? So I think it's very, very important that that comes into play. This is just some information here as far as the relationship of vitamin D and the brain integrity and how they've shown that it definitely has a neuroprotective effects against the amyloid plaques, which is really what people call the hallmark of Alzheimer's disease. And I think that's very important to keep in mind. I think it's also important to keep in mind and not be naive to this, that thinking that going out in the sun for 15 and 20 minutes a day is going to provide us with adequate vitamin D synthesis. So I think we all have to realize at this point, since this is a serious disease and diabetes is associated with this, which is also a very serious disease, that we can't just assume that we're getting enough vitamin D, that we have to have some way of objectively of determining whether or not we have this particular relationship. Now, one of the things, of course, that we hear from time to time, and you might have even told some of your patients this or discussed this with patients, is there's a big fear of calcium. People say, don't take calcium because calcium causes plaquing and causes these problems to occur, these major pathologies, whether it's heart disease or maybe diabetes or some other condition. There's definitely a relationship that we have to look at with calcium, but at the same time we all have to realize that when we have inflammatory reactions in the body, that calcium has a tendency to go to those areas. And a good example is kind of going outside of the vascular system and something like orthopedic, that we know if we have chronic tendinitis in one of our rotator cuff tendons, that we're going to eventually calcify that tendon. Now, does that mean that that person had excess calcium consumption and that's why they had that calcified tendon? No. That's a natural pathological response, is that when we have inflammation, we're going to draw calcium to that site. And so We know that vitamin D, magnesium, various other nutrients modulate calcium or control calcium or have a relationship with calcium. And so this is something that also is very important to keep in mind, and that's why we have to always monitor these nutrients together, that we can't necessarily just look at one nutrient for the answer. So when we talk about, once again, dementia / Alzheimer's disease, diabetes, any of these conditions, we have to look at various nutrients as one factor. And once again, as we talked about earlier, and I'm going to continue for a little bit, is that vitamin D has become a very important nutrient today. And we can't forget about this particular relationship with other pathologies as well. You go into some oncology literature, you go into some immunology literature, rheumatology literature, dermatology literature. Vitamin D has numerous roles, but several years ago we just thought it was primarily a musculoskeletal relationship. So here's a few studies that are actually shown where, like in 2016, Miller and Associates conducted a human study which definitely showed that vitamin D increases plasma alpha beta in older adults, indicative of, once again, decreased brain amyloid beta processes. We also know that the deposition and by N. Weiler and Associates in 2016 also showed some antioxidant and anti-inflammatory effects of vitamin D. And then, of course, a meta-analysis conducted in 2017 also showed the benefits of vitamin D at a particular level in regards to affecting or enhancing or a relationship of dementia. So once again, something that we always are looking at. So one of the things that I think a lot of people are starting to get more and more knowledge on is how effective vitamin E is in regards to an anti-inflammatory effect. I was just reading an article about a week and a half ago talking about higher dosages of vitamin D having a significant impact on osteoarthritis. Another article had to do with autoimmune diseases and vitamin D. So we know that there's different factors involved. These inflammatory cytokines, such as tumor necrosis factor alpha, have been shown to be regulated, once again, with vitamin D. And, of course, there's medications out there that attack this area as well. It's not the only nutrient that does this, but, once again, one of the major ones that we're looking at. And that's why I think vitamin D levels have been started to be watched for the last decade or so, is because of the relationship. We also know that vitamin D has a huge impact on the overall immune system. And this is something that also comes into play. And the ability for us to handle certain pathogens is dependent upon our vitamin D status. And we've known this for years. Vitamin D has a very strong role with the lymphocyte. And as a result, when the lymphocyte is not functioning properly, we know that the antibody production can go down, the migration can go down, and this is going to, once again, get us in a situation that's going to cause some major issues. Then, of course, there's a relationship with nitric oxide and vitamin D, and this is something that has come up with other conditions, other nutrients. For example, B12 has been shown to have a relationship with nitric oxide as well. So it's not just, once again, an anti-inflammatory. It's not just an antioxidant. It's a regulator or has an impact on nitric oxide. It has an impact on insulin secretion, insulin production, and, once again, insulin receptors. So you can see this multifaceted benefits of vitamin D. But my big question to you is, with your patients, are you objectively measuring their vitamin D status to really see if they need it, or can something, once again, come about to show that they are going to be predisposed to another condition like Alzheimer's down the road? Now, this is a good study published in Neonatology in 2018. You can see this pretty new article. And they actually talked about vitamin D deficiency in pregnancy and how this is so impacting on these individuals, these infants, and also on how down the road their immune system is going to be affected. There's another article that was published not too long ago talking about our first 1,000 days of life are substantially going to impact our later years in life. And so the mother integrity, the baby's integrity while breastfeeding or not breastfeeding is really going to have an impact on what's going to happen 10 years, 20 years, 50 years down the road with this particular individual. And I think it's very important because one of the things that comes up often is, well, a woman that's pregnant or trying to get pregnant, can she take vitamin D? Is it okay that she takes vitamin D? Can she take more than 400 international units of vitamin D? And there's more and more studies being done with that, and there's once again studies of toxicology and showing that it once again is beneficial in that way. Neurotransmitters, as I mentioned earlier, that vitamin D does have a relationship with serotonin, as well as some other neurotransmitters, which has to always keep in mind. And of course, dopamine isn't talked about much with vitamin D. When we talk about dopamine, we usually talk about B6, we talk about magnesium in relationship with copper is related to dopamine, and vitamin C is related to dopamine. But here's a good example on how vitamin D combination with some of the medications out there is going to complement the medication to help with these individuals with another central nervous system condition as Parkinson's disease. So now we have a relationship with Parkinson's disease and Alzheimer's, and that commonality is once again vitamin D. When we talk about fat-soluble vitamins or nutrients, I think we also have to keep in mind that if we give a large amount of one, like vitamin D, can it actually impact some other nutrients? And the answer is definitely yes. And this is something that I don't think a lot of people are looking at today. Once again, since I've been in this field numerous years, I've been looking at it for a number of years. But once again, when we give a high amount of one fat soluble, can it cause a deficiency or inadequacy of another? Well, once again, as I mentioned, it definitely can do that, and you can see how vitamin A can play a role with Alzheimer's or with the nervous system. That if we are taking large doses of vitamin D, do you know whether or not you're causing a vitamin A deficiency in an individual? So one aspect, you're helping them from a vitamin D status and those functions, but are you actually causing another deficiency with another fat soluble? That's very important. So here's some more information regarding the effect of vitamin A and Alzheimer's, and also the relationship of beta-carotene levels are found to be, once again, a strong correlation with cognitive function. Now, just to kind of put a twist on this a little bit, since beta-carotene is mentioned here, is thyroid hormone affects the ability of carotenoids to go to vitamin A. And so does insulin. So when people have low insulin levels or abnormal thyroid levels, thyroid hormone, whether it's abnormal prescription thyroid medication or they just have a dysfunctional thyroid, that they don't have the same ability to maintain an adequate vitamin A level through the carotenoids that they consume in their diet. So if you keep that in mind from this point on, that why do some of these people that have thyroid problems also have vitamin A deficiency or other common pathologies that these other conditions are related to? It is because of that hormone or the lack of that hormone that can be causing that. Now, when we talk about vitamin K, of course, vitamin K, we usually think about clotting. Now more and more research has shown that vitamin K is important for cardiac function, important definitely for bone integrity. We know that vitamin K also has a role with myelin, that we cannot produce myelin adequately without vitamin K. So we have a relationship here with vitamin K, vitamin D, and of course another fat-soluble vitamin A. And you can see how they're synergistic in one aspect, but they could be antagonistic as well in a large dose. And this is another reason why I'm a big advocate of multiple dosing. Because when you give large amounts of one particular nutrient, whether it's a water-soluble nutrient or a fat-soluble nutrient, or whether it's an amino acid comes into play or anything like that, you have a better chance of causing a deficiency with a large amount at one time versus multiple dosing. Now, I know compliance is always a concern at that time, but we have to consider that when we are dosing people. Compliance versus dosing versus, once again, benefit. So here's some more information. Once again, I gave you some citations on the benefit of vitamin K in the nervous system. So now you have to come into play and say, well, wait a minute. So is there another relationship that we see with vitamin K and the nervous system? And that is, of course, our microbiome. Because we know our microbiome does have an impact on our vitamin K status. And it's another relationship is when we talk about the gut-brain axis. So once again, it's not just fermented products. It's not just certain plants that contain these different types of vitamin K, but also our microbiome that has an impact. And like I said, I think we're in a very early stage of finding out more and more about our nutritional status and how it has an impact. Now, when we talk about vitamin D, we always have to talk about magnesium. Just like when we talk about magnesium, we always have to talk about calcium. Well, magnesium, as you know, is essential for hydroxylating the vitamin D in our body. So when we take vitamin D in, and whether it's D2 or D3, when we go through the hydroxylation process, magnesium is required in that process. On the other hand, vitamin D enhances magnesium uptake. So they're very strongly correlated with one another. And one of the things that we have also correlated with magnesium, just like vitamin D, is magnesium is an anti-inflammatory product. Now, maybe some of you know this or all of you know this, but elevated CRP as a cardiac marker. Most people say, oh, I give turmeric, or I give resveratrol, or I give omega-3s. Well, that's great. Those things help lower CRP. But are you aware that vitamin D deficiency elevates CRP, or magnesium deficiency elevates CRP? So this is very important to keep these in mind. And also, what's interesting about this is magnesium also has a relationship with insulin resistance. In fact, there's 5 major nutrients that we look at that I see over and over come up when people have diabetes or hyperglycemia or reactive hypoglycemia, but some type of glucose abnormality. And that's B3 is in regards to niacin, in niacinamide or nicotinamide form. D3 is in dog. Zinc, magnesium, chromium. Now, there's other things, of course, like alpha-lipoic acid that come into play, and vitamin E and vitamin C and so on. And like I said, we're limited to time this evening to really discuss all of them. But the point is, magnesium is highly affected by stress. And I mentioned one type of stress earlier, oxidative stress. We know that magnesium helps decrease oxidative stress. Psychological stress has been shown to help deplete magnesium by increasing urinary magnesium levels. And in exercise, physical stress, we see a higher demand of magnesium because of the need for ATP production. So the point is that this is a very important nutrient. And this is a great slide here on showing you how magnesium can impact our insulin resistance or diabetics and ultimately Alzheimer's. Is it has an impact on the receptor site, the binding of it, once again, the overall action of insulin, and of course, as I mentioned, an anti-inflammatory process as well, because one of the, of course, causes of insulin resistance is oxidative stress damages, or is involved, I should say, with insulin receptors. And if we have a large amount of free radicals, that we are going to potentially damage those receptors. And this goes back to that statement I made earlier, that when people exercise heavily, and when I say heavily, I'm talking about maybe 3 or 4 days a week or more, at least an hour, hour and a half each time, and they're not taking care of themselves nutritionally, they are putting some oxidative stress tendencies to a point that could cause tissue damage, whether it's neural damage, whether it's insulin receptors, or whether it's some other organ that's involved. But you have to keep that in mind. So we're trying to encourage our patients to exercise, but at the same time, it may be detrimental if they don't take care of themselves. So here's some more information about zinc and its relationship with diabetes. So once again, if there is really a relationship of insulin resistance with Alzheimer's, then we have to consider all the nutrients that once again have an impact on the production, the secretion, the receptors, and inflammation, any of those that come into play. And definitely zinc is one of those as well. So even though a lot of literature is, once again, out there on vitamin D and the relationship on Alzheimer's, you can see that magnesium and zinc now also come into play as well. Vitamin E, if you look at the literature on vitamin E, of course, we all know it's a very significant antioxidant. It has anti-inflammatory effects. And once again, there's a large amount of individuals that don't even consume the adequate amount of this particular product, and is very, very important. And this particular nutrient has been associated with some of these pathologies: Alzheimer's, diabetes, of course, cancer, cardiovascular disease. We see this particular level be affected with exercise as well. And this goes back, once again, another fat-soluble nutrient that could possibly be affected by large dosages of another fat-soluble. So the next time that you give large doses of vitamin E or vitamin D or vitamin K or vitamin A, is think about the other fat-soluble nutrients that you may be affecting. And this is, once again, another strong argument for objective testing to determine if you are causing any issues. This is a nice study, a Swedish study that was published in 2010, and they looked at the population of, once again, the Swedish octogenarians, and looked at the incidence of these particular individuals with Alzheimer's. And they found that higher plasma levels of course, the vitamin E's, and they looked at the tocopherols as well as tocotrienols and overall vitamin E status, and to see if there was a relationship. And once again, they found that they definitely correlated with a positive relationship, that if they had high levels of vitamin E, once again, had a lower tendency for this particular condition. Now, one of the hormones that's often looked at today is adiponectin. And you might want to say, well, why are we looking at adiponectin? You know, we're looking at this condition called Alzheimer's. Well, adiponectin, as you know, has a strong relationship with insulin resistance. And one of the nutrients that actually has a relationship with adiponectin is vitamin E. And they've actually shown a close relationship on how TZDs work and these two particular products, the adiponectin and vitamin E. So once again, I don't want to go in depth into this particular slide, and you can reference it later, but definitely we know that there have been a relationship of vitamin E and adiponectin and insulin resistance. So that's one of the mechanisms that we also have to look at. Now, I apologize for this particular slide, and I also apologize for not putting the reference here, but I'll reference it later. I'll provide that to SpectraCell so they can get that if you're interested in this particular article. But in this slide at the very bottom, they show the relationship of vitamin E here and how it has an impact on the amyloid development. And there's also a little part of the schematic also that includes vitamin K, and we talked about that earlier as well. So this is an excellent article in relationship of vitamin E and also vitamin K in this particular process. But what about vitamin C? We always talk about vitamin C from an immunological standpoint, and once in a while we'll talk about vitamin C from maybe a connective tissue standpoint, that, of course, making collagen and elastin, things like that. But we also know that vitamin C deficiencies have been involved with the amyloid pathogenesis. And we also know that vitamin C deficiency has been associated with insulin resistance. In fact, there's a few articles out there now that are showing that when people are vitamin C deficient, that they actually have an increased oxidative stress and have a tendency with that increased oxidative stress to damage the insulin receptors. Well, what's a condition that could increase vitamin C deficiency? Exercise. Exercise, especially in your marathoners, your triathletes, your CrossFit individuals, have a higher tendency of vitamin C deficiency. And once again, this is published in sports nutrition literature, and this is one of the reasons why they have found that these particular individuals have increased incidence of upper respiratory infections because of their status of vitamin C. So I think it's very important that we keep that in mind as well. So you can see there's several different things that come into play. And then, of course, one of the other things that people are constantly talking about with central nervous system involvement, whether it's depression, insomnia, anxiety, is the omega-3s. And probably the strongest literature out there in regards to omega-3s is the DHA omega-3. And this is the one that's talked about both in cardiovascular, in stroke, as well as I mentioned, central nervous system involvement. And once again, the question is, are you recommending that to patients, or are you taking that yourself, and are you assuming that you have the right dosage, or are you objectively measuring it? And going back once again to the cardiometabolic panel that SpectraCell provides, is they actually look at the omega level, the omega-3 levels and the omega-6 levels of these particular individuals, and can tell you whether or not they're pro-inflammatory. Do they have a higher omega-6 to omega-3? Do they have a higher arachidonic acid level? Where are they looking at the linoleic acid as well? And of course, once again, something that's very important and will continue to be important down the road. And we always talk about neuroplasticity, and this is one of the nutrients that actually comes into play with neuroplasticity. Well, one thing also interesting, and this is earlier literature, is when you take in a large amount of omega-3s, could that impact anything else? Well, there's some studies that show that high amounts of omega-3s may predispose you to vitamin E deficiencies. And one of the reasons that may be, or the mechanisms, is the oxidation of the omega-3s. As these fatty acids go through oxidation, as they go through oxidation, the body tries to protect itself by, once again, utilizing vitamin E to quench those free radicals, and you become vitamin E deficient. So I think it's very important, once again, to realize that even though we're looking at these particular conditions and these nutrients that help these conditions, are we impacting other nutrients that can cause the same condition? One of the things that, of course, keeps coming up in the literature is exercise is beneficial for mental health. Well, I agree with this 100% as long as you have good nutritional status. As I mentioned several times this evening, that exercise can impact certain nutrients and can cause certain deficiencies that have a relationship with these diseases: diabetes, heart disease, Alzheimer's, dementia, autoimmune diseases. So the point is, even though we are encouraging exercise, we also have to do this in a very controlled manner, and people that are exercising regularly must also be evaluated nutritionally. And like I said, you hear the same type of patients as I do, but Dr. Grabowski, I eat better than 95% of the public, I exercise regularly, and why did I come down with this diabetes? So why do I have this autoimmune disease? And on and on and on. Because they're taxing their nutritional status. And once again, when you go into the literature, you'll see one or two articles speaking about this, but when you look at the nutrients as a whole and exercise as a whole, and you go to various individual nutrients, there's several nutrients that are impacted by regular, heavy, or even moderate exercise, depending on the person's status. That's not even including medications they may be on. Are they on diuretics that are causing magnesium deficiency? Are they on proton pump inhibitors that are causing mineral and B12 deficiencies, which have been associated with Alzheimer's or central nervous system integrity? Like I said, I could talk for hours and hours on this subject and other nutrients, but I wanted to touch certain nutrients that are quite a bit of literature out there on it, and the relationship of diabetes or insulin resistance and Alzheimer's, and how just 4 or 5 major nutrients like niacin and vitamin D3 and zinc and magnesium and vitamin C and vitamin E, and how they have a role in diabetes or insulin relationships and also in Alzheimer's. And that's what I think is very important to get out of this webinar tonight, is it's very multifaceted. And this is why one nutrient isn't, once again, the answer, is we have to continue to search on the complementary effects of each nutrient and what mechanisms that they affect and how possibly nutrient-nutrient interactions come into play and could also, once again, cause a problem. But most importantly, I ask you, are you objectively measuring your patient's levels to determine if you are causing an iatrogenic problem or not with a nutrient deficiency? Or are you giving them some lifestyle directions that are also jeopardizing them, telling them, oh yeah, it's okay to exercise 5-6 days a week for 2 hours each day, and yeah, you're trying to lose weight, so limit your intake of calories to 1,200 or 1,500. Well, when you do that, you're definitely going to limit their micronutrients. And now we have a way of determining that's going to have a huge impact for their future. Now I will answer some of the questions that are available at this time. I guess we don't have any questions right now.
Hi, Dr. Grabowski. They're coming through right now.
Okay. One of the questions is, can glutathione reduce oxidative stress enough that a patient won't need as many nutrients? It is one powerful antioxidant. In fact, some people call it the master antioxidant, but it isn't the only antioxidant. That's what the point that I really want to emphasize once again is there are certain nutrients. For example, you can take N-acetylcysteine, but you need riboflavin to help convert that into glutathione. We know that vitamin C helps protect glutathione. We know selenium has a relationship with glutathione. We know magnesium has a relationship with glutathione. And yes, glutathione is a very important antioxidant in our body, but the point is it's not the only antioxidant. And that's why we don't have this nutrient out there that's going to solve everything. They're so synergistic, and various factors affect these. And that's why sometimes I hear doctors tell me, well, Ron, I give N-acetylcysteine to, elevate this person's glutathione level. Well, that sounds good, but what about B2? Are you doing anything for riboflavin? Well, I haven't checked riboflavin. Well, you need to check riboflavin because you can give a large amount of that and you may not actually get the benefit of glutathione. And there's, other antioxidants, as we all know, out there, and that's why it's so important. And like I mentioned, it's not just oxidative stress that we have to look at. We also have to look at these other mechanisms in regards to the diabetes or the insulin resistance with the Alzheimer's, as far as, are you producing the insulin? Are you secreting the insulin? And are you, do you have optimal insulin receptors? One of the questions is, why does calcium go to the area of inflammation? It's just, I can't tell you exact mechanism why this occurs, but we do know that one of the things it may have to do with an acid-base relationship, and of course we know that calcium has more of an alkaline type of relationship. It's just like the same thing with, we know we do change the pH of the body when we have inflammation. It's just like when you have more of an acidic urine, you have a tendency to lose more calcium because, once again, it's kind of like a buffering mechanism. When you have an alkaline urine, you have less chance of, once again, dumping calcium. And that's why we have this, when people consume a lot of protein, animal protein per se, and you acidify the urine, you have a tendency to develop calcium oxalate stones more readily than if you go into an alkaline urine. So we think one of the relationships may be that acid-base balance. And our body has that relationship. And when we talk about acid-base, it's very important to remember that there's three main ways that we keep our pH balanced. It's our respiratory system, our kidneys, and our hemoglobin. Those are the major mechanisms that maintain our alkalinity or the acidity of the body. And if any one of those systems is affected, if we're anemic or we have kidney dysfunction or we have respiratory dysfunction, we're going to affect our pH. And it's one of the things that we look at. But we do know that when we have inflammatory process, chronic inflammatory process, that you're going to bring calcium to that site. Okay, one of the questions is, are isotonic vitamins better than capsules or pills? Well, I had one of my patients ask me this because he came in today and he's consuming all drops. All his vitamins and minerals were in drops. And I said, Bob, why are you consuming drops? Why aren't you consuming capsules? Why don't you consume tablets? Or what made you go to drops? He says, well, they're better absorbed. I said, well, why do you say that? He says, well, because they're in a liquid form already. Well, the thing that you have to realize is it's really the form of the nutrient that's very important. For example, you could have a magnesium oxide that is in liquid form versus magnesium glycinate that's in a capsule form, and you're going to have a better bioavailability with magnesium glycinate than you will magnesium oxide. And it has to do with several mechanisms, of course, and the carrier, whether it's an active transport and the size of the structure and so on. But the point is, just because something is in liquid form, it doesn't necessarily mean it's a better absorbed product. Yes, it may be accessible earlier on, like in the stomach and early proximal small intestine, but the bioavailability of those nutrients, there's several mechanisms that, once again, and one of the best books out there, I think, that can help clarify that to you it's called Amino Acid Chelation in Human and Animal Studies. And it's published by CRC Press. And it's a very in-depth textbook that goes into the bioavailability of minerals and why amino acid chelation is so important. And I really recommend that you go to that particular textbook. So the last question is, what is stepwise protocol for working up deficiency in Alzheimer's? Well, one of the things I want to emphasize, you have to look at multiple nutrients, micronutrients. You have to look at the amino acids, you have to look at the vitamins, you have to look at the minerals,